alveoli and interstitium. We have B lines, where we have the hyperechoic vertical line seen here moving back and forth, present in pulmonary edema, pneumonia, diffuse alveolar hemorrhage, anything where there is filling of the alveolar interstitial space or scarring of the interstitial space. Consolidations are present in pneumonia or dense atelectasis once you've totally de-aerated the lung, making it look like a solid organ. D stands for diaphragmatic ultrasound, and this is a growing field where we can understand the main muscle of respiration, and we can say whether or not that's a part of the cause of somebody's respiratory failure. E is for pleural effusions, and you can see that free fluid here. F is for feeding tubes, with this idea that we get a chance to see whether or not the feeding tube is traveling down the trachea or through the esophagus. We can also see the vocal cords here if you're thinking about evaluating that, but that's a more advanced skill set. G is for gastric emptying. In the era of GLP-1 inhibitors, it's really important to understand whether our patients still have a full stomach prior to intubation, or if that full stomach might be impairing their respiratory excursion. And then, just like my youngest daughter, we'll skip a few letters of the alphabet. We'll jump down to S, where we'll get to lung sliding, which allows us to rule out pneumothorax. T for a thickened pleura, which is present more in inflammatory and infectious states and allows us to differentiate them from the alveolar filling of cardiogenic volume overload. And Z for the Z lines, throwing back to the French originator of the lung ultrasound alphabet, which are present in healthy lungs, not necessarily a sign of pathology, but do rule out pneumothorax. Great. Now let's go into some of the lung ultrasound applications that are present for any specialty, not critical care specific. When it comes to lung ultrasound for hypoxemia, the original trial that Liechtenstein published was the Blue protocol. And what this does is he basically said, hey, I'm going to use no clinical information other than the lung ultrasound for a bunch of hypoxemic patients and tell you what their cause of hypoxemia is. I do want to put a little caveat here. Please don't do that. Please always use the clinical information that you have available to you, physical exam and history, labs, when you're trying to figure out the cause of respiratory failure in your patient. But I'll highlight the way that this was used. The first question he asked is, hey, is lung sliding present? And you can look here at this clip where I highlight the glistening, shimmering of lung ultrasound, and you can say, yes, lung ultrasound is present. We go down this channel. As a reminder, this is what non-present lung sliding would look like in a patient who had a pneumothorax. So, since we know lung ultrasound is present, the next thing we have to ask is there an A profile diffusely or a B profile diffusely? And if you look at the same clip that we were evaluating before, you can see that there are B lines in comparison to the A lines highlighted, the blue arrow pointing to the pleura, the black arrow is pointing to the A lines, both here and the B lines in this other clip. So based on the clip that I just showed you, with a present lung sliding and a diffuse B line profile, we would say that this patient most likely has pulmonary edema. The thing that I do want to throw out there is if you look at that algorithm, you can see that there's a lot of different ways to get to pneumonia, and it is useful to think about pneumonia because it's such a common cause of respiratory failure. We have a lot of different findings in lung ultrasound that are present in pneumonia. Air bronchograms, which are the most specific finding, a focal area of B lines, a para-consolidation effusion, subpleural consolidations or thickened pleura, and consolidations, frankly, being a sign of pneumonia. So if we think about that blue algorithm, we can see that there are multiple different pathways that end with pneumonia as the final diagnosis, whether that's an A profile with a focal area of B lines at the base, or if it's just a mixture of A lines, B lines, and consolidations, or if it's a absent lung sliding with B lines just about everywhere. So we want to think, is this a useful test? And when we look at the results from Liechtenstein's original paper, they may seem unbelievable. Look how high that accuracy is between those sensitivity and specificity figures. I'll offer that this is a select cohort that didn't include patients with pulmonary fibrosis, post-transplant, anything like that. That said, when we ask ourselves specifically about some of these diagnostic buckets, such as cardiogenic pulmonary edema, meta-analyses of thousands of patients continue to show extraordinarily high sensitivity or specificity, especially when compared to the diagnostic accuracy of chest radiograph or physical exam. Similarly, pneumonia, which had a sensitivity and specificity in Liechtenstein's study of 89 and 94%, has followed up in meta-analyses to have similar diagnostic performance much better than what you'll get out of a chest radiograph or auscultation. Knowing that this is a useful diagnostic modality, let's think about the ways that it's already been used. And this is a study where we said, hey, if we have lung ultrasound and a pulse oximeter, do we really need the chest radiograph and ABG that we use to diagnose ARDS? There's a more general set of how to do this for the cardiologist in order to help them understand it. And we can get beyond just ARDS and volume overload to start looking at how to apply this widely, to the point that we can think about, is this a portable CT scanner instead of thinking about this as a portable chest X-ray? We can apply this in our patients with inflammatory lung disease and think about a rapid way in the clinic to detect the efficacy of immunosuppressive therapies. And this started to grow, and we could see year after year the number of publications looking at applications for lung ultrasound was growing until 2019. And then came the COVID pandemic. POCUS in general, not lung ultrasound specifically, but all over, thrives in a resource-limited setting, whether that limited resource is time, radiology equipment, space, or providers. And from the very beginning, we were getting descriptions of how lung ultrasound was presenting in patients with coronavirus and coronavirus-induced ARDS. We talked about how you could integrate this, and Dr. Risa Lewis and others created an article just describing that POCUS was having its moment in 2020. This is becoming standard of care in ICUs, and the pattern of lung ultrasound was being used to help us differentiate some of the questions that we had before. Is this ARDS? Is this volume overload? Is this both? And so this was an explosion of research, and I put that in quotations because while some of these are really useful clinical case reports, and some of these are very informed lung ultrasound anecdotes, the number of research articles doubled in a single year. And we really want to think about this as something we should be excited by, but also something that we should study with the same level of rigor that we would any other diagnostic modality. Because if we think about the patterns of lung ultrasound that were described in COVID ARDS, they're the same that are described in just about any form of ARDS, whether it's viral or bacterial. Outside of ARDS, lung ultrasound is used in patients with end-stage renal disease because we know that volume overload is such a critical part of their care. And we were able to do a study showing that the number of zones you scan will affect your accuracy, and that the number of B lines per zone can predict whether that patient is going to end up in the hospital or dead at the end of 30 days. We even started thinking about, can we use lung ultrasound to just forecast whether or not a patient is going to do well if they have end-stage renal disease and signs of volume overload? This collection of research got to the point where the American College of Physicians did a review of all the evidence and put appropriate use of POCUS for patients with acute respiratory failure in their recommended guidelines. And you can see that they were able to say POCUS augments our clinical ability, adds to physical exam and history. So that's more generally how we use lung ultrasound, but I want to talk about my favorite area, which is the ICU. So how do we use this in patients who are critically ill? And one of the things we can do is we can just say, hey, our patients are sick and complex, and oftentimes a chest X-ray does not give us sufficient information. And so a direct comparison of lung ultrasound to chest X-ray with CT scan as our gold standard shows us not just that ultrasound is more accurate than chest X-ray with CT as gold standard, but also where the places that lung ultrasound is going to fall down will be. And specifically, I'm talking about if you have areas of peripheral bullous lung, that's going to block your ability to see anything that's deeper and more anterior. Or if you have a mass that is surrounded by normal lung tissue, ultrasound won't see it and CT scan will. Or if you have a pneumonia that's hidden behind a gastric bubble, as is the case in this last slice of a CT, then you'll have a false negative on your lung ultrasound. This sort of refinement of the specific diagnostic accuracy of our patients is incredibly helpful in knowing how to use lung ultrasound in the ICU. Beyond that, one of the hardest questions that I sometimes am faced with is this opacity on a chest radiograph infectious, or simply a matter of a patient being supine for too long and having atelectasis? And this study said, hey, can we use a couple of different findings to differentiate this? And you can see here an example of a patient with dynamic air bronchograms, which they found to be highly specific for pneumonia in comparison to atelectasis, with a specificity of 99% in their analysis. They also added color Doppler of these to see whether you could have signs of hyperemia in your infected patient versus normal blood flow in your atelectatic patient. The other thing that comes up frequently in the ICU is, does this patient have a new ventilator-associated pneumonia? And while we can do this with our existing standards, using chest radiograph showing new opacity, increase or change in character of sputum and other lab values, using lung ultrasound can help us make this more accurate. And this was a nice protocol where they said, hey, we want to suspect ventilator-associated pneumonia if they have one of these findings. Then we're going to do ultrasound, and we're going to add points to our ultrasound to make a score, and we're going to take the combination of clinical indicators and ultrasonographic indicators, and they demonstrated that this is highly accurate for the clinical diagnosis of ventilator-associated pneumonia. Another question that arises is this a simple volume overload driven effusion, or is this an effusion that's becoming an infected space that we need to think about drainage of? And so this is where we looked at, can the ultrasound findings differentiate transudative from exudative pleural effusions? And what we found is that anechoic fluid does not help change our post-test probability of this being transudative or exudative. But a highly echoic fluid, as seen here, or a loculated space, as seen here, are super helpful for helping us understand whether or not this space is infected. Beyond just diagnosing whether or not we think that a fluid space around the lung is infected or not, we need to be using ultrasound to guide our thoracenteses. And whether that's just marking a space and making sure that there's no blood vessels, as seen here, or in this new protocol proposed in the POCUS journal, are we thinking about a standardized approach for visualizing the blood vessels above and below the space in which we're thinking about putting our needle in order to understand if our patient has an unusual vascular anatomy that would put them at higher risk, as seen with this artery that's somehow right in the middle of the rib space. We can also think about using POCUS to meet our diagnostic criteria for ARDS. This was originally described in what's known as the Kigali modification of the Berlin criteria for ARDS. But in the last year, both the American and European groups have created new definitions for the acute respiratory distress syndrome. And you can see specifically that they call out ARDS in a resource-limited setting where you can use POCUS instead of chest radiograph or chest CT to meet your necessary imaging diagnostic criteria of bilateral abnormalities. Beyond just making the diagnosis of ARDS, though, we can use scoring systems that have been proposed for understanding whether or not people are getting better. And so this is where you take somebody who has ARDS and you look at each zone and you say, does that zone have an A-line pattern, a pattern with discrete B-lines, a pattern with confluent B-lines, or consolidations, and you give them points increasing as they move from one to the other. Based on these number of points and sum, you can start to understand a little bit about not just the severity of the imaging findings of their ARDS, but also are things getting better or worse. So for example, one of the first ways that they used this was to say, hey, can we use this to guide recruitment with PEEP? And they did this by taking a patient down to 0 PEEP, or ZEEP as it is colloquially known, and then adding PEEP and seeing what happened to the lung ultrasound findings to identify recruitable zones of lung. The protocol here is very clever, and they were able to show that this indicated which parts of the lung were going to be recruitable and which parts weren't. When they did that, they had very tight correlation with their exhaled tidal volumes. The other primary therapy for ARDS that we know works is prone positioning for moderately severe ARDS. But sometimes we will wonder in our patients who might be at higher risk for proning, whether that's for hemodynamic instability or for skin vulnerability, we'll wonder whether they're likely to benefit from an oxygenation standpoint. And so this study was able to show that if you look at those lung zones and score them in the same way that we did before, that you can predict a pattern, more posterior, higher scored zones, being the patients that are more likely to have a response to prone positioning. And that response is seen both in imaging and potentially in oxygenation. I do want to put the caveat here that I teach all of my trainees, which is that the benefits of prone positioning in terms of mortality in ARDS are not necessarily dependent on the improvement in oxygenation, but this can be helpful when we're trying to come up with a plan for the day. As I said before, one of the main questions we have in our critically ill patients is, are the imaging abnormalities I'm seeing from volume overload, or are they from progressive ARDS, cardiogenic or non-cardiogenic pulmonary edema? Capetti et al. Tried to answer this by looking at groups of patients that had known ARDS and groups of patients that had known acute pulmonary edema. And when they did that, what they found was that B-lines were present for all of these patients. But if you looked closely at the pleura, you could see a pattern where the cardiogenic pulmonary edema patients had smooth B-lines, and the ARDS patients tended to have more commonly pleural changes. Similarly, you could look at reduced or absent lung sliding and the presence of consolidations or effusions as being useful for differentiating the two groups. This has been validated in further follow-up studies, helping us understand the utility of this technology. If you have identified that your patient is volume overloaded, then lung ultrasounds has a new utility, which is, hey, how much congestion remains? Because you can quantify it in a way with B-lines that you really can't with chest x-ray. And so when you look at this, they looked at patients who had more than 15 B-lines and they said, wow, this really predicts event-free survival from heart failure patients when they're discharged. Those are the ways in which lung ultrasound is currently being used. I want to talk now a little bit about where I see the future of lung ultrasound going. And one of the first places is expanding the indications. We're learning more and more about how lung ultrasound presents in different pathologic etiologies. And so, for example, PE, which is typically described as just having clear lungs, can actually have small microconsolidations, and you can look at the blood flow inside of them to say, hey, is this because of an infectious inflammatory etiology, or is this because a clot is preventing blood to get into that portion of the lung? And then there's this idea that you could use ultrasound contrast to actually see the blood flow inside of the lung and understand where in the lung is not getting blood flow. Beyond this, I like the idea that lung ultrasound is easy to do, and so it should not be limited to just the intensive care unit. Obstetrics and gynecology residents are learning how to do this to help look for peripartum and postpartum cardiomyopathy. They're looking for amniotic fluid embolism. The family medicine group has said in their ACGME guidelines that this should be a part of every primary care doc's residency training. And when it comes to intraoperative lung ultrasound, there are a number of ways that you can apply this while the patient is on the table in the OR. And then afterwards, you can look at their lung ultrasound findings to see whether you can predict who's going to have this more complex postoperative course. Not just limiting this to the area of the intensive care unit, we can think about not just limiting it to physician scanners. We can see that APPs are starting to do this, and respiratory therapists globally have started to be involved in research on the applications of lung ultrasound performed by RTs. Nurses have been using lung ultrasound in order to make diagnoses of pneumonia in dyspneic patients and to help with triage in the ER. And then if I'm trying to think about where the best financial return on investment is with the prevalence of heart failure, it's got to be understanding if I'm making progress in getting my patient to their ideal volume status as quickly as possible. And so this is demonstrated in studies where we're trying to teach internal medicine teams to use lung ultrasound to drive their diuretic goal, to decide when a patient's ready for discharge, or to decide whether or not a patient's going to be readmitted. As I said before, lung ultrasound is a study of artifacts, and so we're learning how to refine our technique in order to make sure that those artifacts are as visible as possible, and that might mean changing the depth, the gain, which presets happen in the back, and where we set our zone of focus. We also have the idea that the traditional zones of lung ultrasound are not necessarily the only zones of interest, and maybe we should be just sweeping the chest, understanding from top to bottom and covering a lot more surface area in order to get a better big picture. When it comes to the even more advanced cases, if you already have a transesophageal chest, where they were able to show that by doing so they could identify a PE or a patient with refractory atelectasis while in the TEE suite. And then we have been stuck with this handheld probe for a long time, and I love it, but there are more and more scientists working on the idea that we're going to just put ultrasound wherever we need it to be and can leave it there in order to understand over time what's happening below that ultrasound patch. Outside of the hospital, we were able to show that you can do lung ultrasound on home visits and answer important clinical questions in a patient that can't be moved to a chest radiograph or who can't have blood drawn easily. And you can use this to adjust therapies in the hospital at home patient. And if we're saying we don't need to be in the hospital and we're saying we don't need doctors to do it, then the next step is, can we have our patients doing lung ultrasound on themselves? And the answer is probably yes, as an increasing number of case series have demonstrated. So to wrap this up, just think about what I want you to take away from today's talk. We briefly reviewed lung ultrasound, and I said before, and I'll say it again, this is one of the easier applications for POCUS. We have an alphabet that helps to guide us, and it works for all sorts of different lung pathologies. When it comes to how we're using it, we're starting to understand that for just about everything, it's better than a chest radiograph, and you can see a lot of different pathologies with it, not just our traditional volume overload versus COPD. And it's becoming a part of the general guidelines for specialty and national societies. In critical care specifically, we can use it to make diagnoses, and we can use it to predict response to the therapies that we use for our patients. And in the future, we're going to have this being applied outside of the ICU, outside of the hospital, being used by non-physician providers and by patients themselves, breaking the boundaries on how this technology can be applied. Thank you so much. As we conclude, lung ultrasound is growing in popularity. The evidence base is exploding. In critical care, our ability to detect ventilator-associated pneumonia, pneumothorax, and modify our ARDS management is incredibly exciting, and the future of lung ultrasound is going to incorporate a lot of new techniques. Here's some citations. That was a bit of a whirlwind of evidence review. Thank you so much. I'm excited to talk to you about questions.
All right. Thanks so much, Cameron. Get you unmuted here. All right, that was our presentation. So we have time for Q&A now. So if you have any questions, you can enter them in the Q&A box at the bottom or the side of your screen. Cameron, thanks so much for being here with us. Let's see, it looks like we do have a couple of questions already. Let's see, can you speak a little more to the training and implementation of Lung POCUS?
Yeah, this is one of the things that gets me really excited about lung ultrasound. I mean, I mentioned that uh, we got to compare lung ultrasound to by medical students with an hour of training to ultrasound done by people who've been using ultrasound for 10 years, and their ability to count B-lines is basically the same. The more exciting part is when can you get the kind of accuracy that Lichtenstein offered in his papers, or where you can say you're more accurate than a chest X-ray for pneumonia. And I'll tell you, the number is still less than 20 scans after several papers kind of looking at this. And that's just an achievable number for anybody. We can integrate that into medical school training. We can integrate that into RT school training. We can integrate that into residency. And my favorite place to target with this is residency, because if you can get people to change their clinical diagnostic algorithms and integrate ultrasound as is recommended by the American College of Physicians, as opposed to saying, I'm just going to use ultrasound, or I'm just going to use something else, then we increase our diagnostic accuracy. And that means we get the right answer faster. I like to joke that when a typical patient that comes in who has a history of heart failure and COPD and volume overload and airways disease and might have a pneumonia, and you're trying to figure out what to do, that we almost always end up giving them steroids and diuretics and antibiotics, and we kind of hope that it all comes out in the wash. And usually it does, but that the side effect profile of all these things means that we're not being as elegant as we could have been. And this is where lung ultrasound can make a difference. It can just let us nudge ourselves one way or another to say, hey, you know what? I see diffuse B lines. We're going to diurese before we do steroids. That we'd be fighting each other otherwise. Or, man, we can finally see this focal pneumonia. We can focus on our antibiotics. We don't need to worry about diuresing this patient who might be becoming septic. And so, to me, the training question is really one of how do we best integrate this into the training paradigms that exist for different professions, so that we can get people to start using this at a time when it matters, as opposed to when they've already developed their own protocols and we're trying to convince them to change something. I don't know if that's what you're hoping for, Chris.
Yeah, that was great. Yeah, we've got a couple more here. Can we use this for the extubation of the trachea?
Yeah, so I think this question is asking about, can we use this to see tracheal edema? And the answer to that is maybe. I don't know of any studies that looked at this, and the challenge is that the airway is really tricky to visualize because there's air in it, and the specific place where you'd be looking for edema, you've got the balloon of the endotracheal tube, and so that makes it a little tricky. Now, if you're asking about extubation in general, is this patient ready? That's been studied a little bit more. And so if your reason for intubation was, for example, volume overload, then because B lines disappear in real time as you diurese somebody, the answer is yes. And the number of B lines can predict their likelihood of reintubation. for me, I'll be honest, I don't count B lines and decide whether or not to extubate somebody, but I do look and see, hey man, there's still a lot of B lines. I'm going to be extra aggressive with my diuresis before extubation, and I'm going to think about, is this the patient who I extubate to positive pressure, to BiPAP or CPAP, rather than extubating to high flow or nasal cannula. And so again, thinking about this not as one thing, but just giving us information about the overall alveolar interstitial space, and kind of letting that drive our decisions. Separate from parenchymal ultrasound, there is a body of literature, and I got to write a review on this about whether or not we can use diaphragmatic ultrasound to decide who's going to do well after extubation. And diaphragmatic excursion, the answer is almost certainly no. When somebody's on mechanical ventilation, that's just driven by the vent. And diaphragmatic thickening, the answer is maybe. It does predict reintubation. It does predict weakness post-extubation. The challenge with this is it really is only doable when somebody's on minimal ventilator vent settings. They have to be on very low pressure support in order to have a meaningful diaphragmatic thickening. And this is a higher level skill. It takes time to get those sort of millimeter measurements to get really good at those, as opposed to just counting B lines, looking for patterns of A lines, B lines, consolidations. But if you do get good at diaphragmatic ultrasound, especially if you're working in a transplant center, or a cardiac surgery center where you're seeing a lot of people who have potential for damage of their phrenic nerves or their intercostal nerves, then this can be really useful. You can say, oh man, this person has diaphragmatic paralysis. We're going to think about early tracheostomy if everything's pointing that way, as opposed to late tracheostomy. Or maybe we're going to think about extubating right to positive pressure ventilation again, because we're anticipating that they're going to have a weaker diaphragm and a longer time for recovery. So yeah, so I do use it for extubation, but I ask specific questions, and I think about optimizing the patient based on their lung ultrasound prior to extubation. In the right patient, I think about, is their diaphragm so weak that I want to think about rescue maneuvers before pulling the tube?
And next question we have, do you feel that ultrasound is replacing an echocardiogram?
Yeah, I mean, this is an interesting question. I'm going to like parse this out a little bit. I think the real question is point of care ultrasound replacing cardiology and cardiosonographer performed echocardiogram? And this is a place where people's fiefdoms get challenged sometimes, and I've heard and seen cardiology departments that are very defensive of this for good reasons. They want to make sure that the information that's being provided at ultrasound of the heart provides good information and not bad information, because bad information is worse than no information. And gosh, they'd rather you call them at any time of day or night than try to do it yourself and get bad information from it. And so I like to differentiate the two. In the same way that a radiology performed CT scan is better if you know the clinical question being asked, but really is a, hey, tell me everything you see. I want to look from top to bottom, and I want to diffuse examination based on a protocolized time and slice and thickness and this sort of thing. And a full echocardiogram done by a cardiology department similarly is I'm going to evaluate the heart from 20 different viewpoints and make sure I am getting every single valve interrogated, every single flow rate interrogated, every single chamber size interrogated. This is a bigger study. Whereas a point of care ultrasound of the heart is really saying, I have discrete clinical questions that I'd like to answer. Is this patient in shock because of decreased ejection fraction, because of a pericardial effusion, because of a failure of their right ventricle? And similarly, I think of lung ultrasound as providing these discrete answers. Now, if the question was, is lung ultrasound replacing cardiac ultrasound? Then we get into my favorite thing, which is none of these things should be done in isolation. We should be doing all of these together. Everybody who wants to ask a question about respiratory failure or shock or whatever it might be should be looking at the heart, the lungs, the deep veins of the leg, in order to put together as much knowledge as possible. And with each of these examinations, they're asking specific questions. Because if your question is, hey, does this person have cardiogenic pulmonary edema? It turns out that lung ultrasound is superior to echocardiogram for answering that question. If your question is, what's somebody's wedge pressure? Lung ultrasound and cardiac ultrasound are like starting to get close when you look at the performance of this. Nothing as good as a right heart cath, obviously, but the idea being that a much easier test can tell you a lot in the right patient. So when I do a lung ultrasound of somebody who I know has heart failure and I'm worried about their volume status, and I see a lot of B lines, I don't need to do very complex diastolic measurements of the pressures in each chamber of their heart in order to say, oh, this is volume overload. Now, if I have the time to do so because it's not a clinical emergency, gosh, that additional information can increase my diagnostic confidence and allow me to avoid, again, those unnecessary therapies that have additional side effects. I hope that got to the kind of meat of the question you're asking about whether or not this is replacing echocardiogram. Again, if I was to summarize that, I'd say POCUS of the heart doesn't replace echocardiogram. It augments it in the right clinical setting, allows us to decide who needs a full echo. And point of care ultrasound of the lungs, I don't think is replacing cardiac ultrasound, but gosh, does it answer better some of the questions that we sometimes ask cardiac ultrasound, thinking that it's going to answer for us.
Right. We do have a couple more questions here, and just a reminder, everybody, you can get your questions in with the Q&A box at the bottom or the side of your screen there for Dr. Baston. Let's see. Next question is, how do you integrate lung ultrasound with other POCUS exams?
Oh, great. This tails off nicely of what I was just talking about. This idea that when we're doing a lung ultrasound in critical care, we're really trying to decide what someone's source of respiratory failure is. And we talked a lot about the evidence that allows us to do that. But think how much more powerful it is if I can say, all right, there's a ton of B lines. I'm trying to figure out if they're cardiogenic or non-cardiogenic. And maybe I've got some of that pleural thickening. Maybe I've got some of the pattern recognition that allows me to nudge one way or the other. But then I look at their heart and they have small chamber size, hyperdynamic left ventricle, small left atrium, small IVC. And then I go, oh, this is probably non-cardiogenic pulmonary edema. I start thinking about diffuse alveolar hemorrhage. I start thinking about ARDS and the setting of sepsis or pancreatitis or anything else like that. Um, and then I get to do the same thing when I think about deep vein ultrasound. So I can do an ultrasound of the all lungs, and I'll be like, oh, straight A lines. This is going to be probably an airway pathology, or thinking about normal lung, COPD, asthma. And then I'm thinking about DVT PE as another potential way to get A lines in a patient who's in respiratory failure. And that's where I add a deep vein scan. And all of a sudden I've nudged my pretest probability a little bit. Now, if I don't find a deep vein thrombus, that doesn't mean that P is off the table. But gosh, if I find one and I've got clear lungs and respiratory failure and tachycardia, then I'm starting to really think PE. And if I have the opportunity then to do a look at the right heart and see, oh man, the right heart's dilated, that means something. Again, a small right heart does not rule out small PE, but ooh, I have started to put together a multi-window view of what could be causing somebody's respiratory failure. So for me, in the same way that we would be surprised if somebody walked in with a stethoscope, listened to a couple points on somebody's chest, didn't listen to heart sounds, didn't examine capillary refill, didn't look for modeling on the legs, and said they did a complete exam. I think this needs to be integrated with all the other places that we can put a probe that are aligned with the diagnostic investigation that we're performing. Pulling it together gives us more power. And that's been shown. There's a study in chest where they actually just compared echo alone versus echo with lung ultrasound and showed that the diagnostic accuracy was better when you had two windows into the body as opposed to just one, which is not surprising anyway.
Great. Next question is, do you use POCUS to help you identify the right site to put it in a chest tube and pneumothorax? For instance, how far from the sliding point area do you choose for the chest tube?
This is a great question. So short answer, yes. I do all of my chest tubes with ultrasound guidance in the absence of cardiac arrest, and this is an emergency, where I don't have the time to even wait for the machine to come into the room. But if I'm there and I have the machine, then yes. And so then it divides into, do I have time to check for vessels? Yes or no? And then I have time to see if there's lung sliding in the reasonable anatomic targets. So first thing I'll do is I'll check and see if I can see areas where lung sliding appears and then disappears. The lung point is as it's described in the literature, the place at the bottom of the pneumothorax. That lets me know I need to be one rib space above that when I do my chest tube. The second question, though, is, do I want to do a Seldinger technique chest tube, or do I want to do a dissection or open technique chest tube? And I do both of those in my practice. In general, I think that a Seldinger technique chest tube is a little more elegant. It's a smaller hole initially. With the kits we have involve a smaller tube size by default. So I think of it as less discomfort for the patient, a smaller hole to heal afterwards. But if I can't find that full rib space above where lung sliding appears and disappears, then I probably won't feel safe putting a needle in order to do a Seldinger technique chest tube for fear of having hit the lungs. I think that in that case, discretion being the better part of valor, I'd rather do a dissective technique and use my finger and be able to feel that I'm in the pleural space before putting the tube in. So the short answer to your question is yes, I use ultrasound. The longer answer is But if I can't find that safe space, one rib space above where there's any change between lung sliding and not lung sliding, but I know that this is pneumothorax, then I still will put in a chest tube. I'll do dissective technique instead of Seldinger technique. And then if I'm doing that and I have the 30 seconds, then I'll quickly switch to a linear transducer and put on the vascular preset to make sure that there's not that weird anatomy. There's a lovely study where they looked at CT angiograms of patients to see what percentage have these really atypical vascular anatomy in their intercostal spaces. And then this is specifically looking at, instead of the above the rib space being clear, they have vessels right in the target of where you would go with a chest tube. And there's certain risk factors that increase that. So age, if it's a much older patient, I'm definitely going to look for vascular anatomy if I have a chance. Dialysis or other sources of fistulas, because they're going to have these weird vascular tortuous paths for their veins that can cause life-threatening bleeds. So yes, when I have the chance, I use ultrasound. If somebody is actively getting CPR and we think that massive hemothorax or tension pneumothorax is a cause, then I'm decompressing first with a needle and then going in with a dissective chest tube with or without ultrasound.
Awesome. All right, next question is, could you speak to some of the pitfalls of using Lung POCUS?
Oh yeah, this is great. Sam Brown really likes writing these articles about pitfalls of POCUS, and I've learned so much from reading his things. And just as you do this, you find the places where things are not as clean as they were in Lichtenstein's studies or in some of the other literature. So part of it is that everyone thinks, oh man, this is super easy. I'm going to put the probe on, I'm going to see A lines or B lines. But it turns out that the angle of incination for the new learner is a real source of error. And what I mean by that is if you're perpendicular to the skin, that doesn't necessarily mean you're perpendicular to the pleura. And you need to be perpendicular to the pleura to really get the A lines because of that bouncing back and forth between the skin and the pleura. And it makes the B lines much more bright. So being perpendicular to the pleura might mean fanning a little bit inferiorly when you're high up, and it might mean fanning a little bit medially when you're more lateral, looking at your different zones. So the first thing is just understanding that there is a little bit of hand skill to lung ultrasound. Again, that's why it takes 10 to 20 scans before you're really getting these diagnoses. Another pitfall is, we talked about this in Dave Tierney's paper where he compared chest X-ray, lung ultrasound with CT scan as the gold standard, which is if you have even a thin layer of bullae or normal alveoli, the sound waves see that. So you could have a really early, really severe bronchopneumonia that hasn't yet spread to the periphery of the lungs, and lung ultrasound won't see it until it does. For me, the anecdote that really highlights this is I once took care of a patient who drowned. And as I was doing the lung ultrasound, it was straight A lines. They had come straight from the river to the hospital, and there was A lines everywhere. And I was very confused. And then 45 minutes later, it was B lines everywhere because that's how long it had taken for the fluid to get all the way out to the periphery. And I just scanned too early. It had filled their respiratory tree, but not yet filled all the distal alveoli. And so I had this very distinct false negative, where I saw a normal lung when it was clearly not normal lung when you looked at chest X-ray or on a CT scan. So there's that. And then, the truth, there's Occam's razor saying one unifying diagnosis is the most likely, and then there's Hickham's dictum that says a patient can have as many diagnoses as they please. And I see this with lung ultrasound where it's like, yes, some people do have volume overload and a COPD exacerbation and a pneumonia. And lung ultrasound's just going to show you the one that's layered on top. And so the place where lung ultrasound can cause us to fall down, a pitfall is if we think that it's better than all of our other indicators, because there will be other indicators if there are multiple pathologies happening simultaneously. So holding on to the understanding of which direction the error is going to be, we're going to see B lines. That doesn't mean that somebody doesn't have a COPD exacerbation. It just means that they also have an alveolar interstitial process. And thinking about what their labs show, what their fever curve shows, all these other things that we use clinically to decide what somebody's source of respiratory failure is. In the ICU especially, when somebody initially gets intubated with one problem, then comes up with another, we can have real issues. That's my issue. Those are some of the pitfalls from parenchymal ultrasound. I talked a little bit about the pitfalls with diaphragmatic ultrasound, with the idea being that if you're looking when somebody's on the vent, you may not see any thickening of the diaphragm. And with effusions, the challenges I've seen people mistake the gastric space for pleural effusion when it's full of liquid. And I've seen a lot of people think they're looking at the pleural space when they're actually looking at ascites, subdiaphragmatic fluid, because that curve of the liver is mistaken for the diaphragm, even though the diaphragm's kind of flapping around in the fluid. To me, the cure for all of these latter ones is just a really good understanding of the clinical scenario and a really good understanding of the anatomy that you're actually looking at. Because ultrasound lets you see stuff, but if you don't know what's supposed to be there, then it's really hard to know how to interpret what you're seeing. So yeah, the first few thoughts on that.
That's great. I did notice one of the attendees, Judy P, they had their hand raised. But if you could put your question in the Q&A box, I'll make sure to get that to Cameron. And while we're waiting for that, you talked a little bit about kind of scanning techniques and stuff in that last answer. What are some of the strengths and weaknesses of the sweep technique that you outlined?
Yeah, this is really interesting to me. So this was proposed several years ago, actually, as a way to allow people with very little experience with ultrasound to do a full lung ultrasound. And the technique is you take the transducer and you just, without stopping, record a video as you move the transducer across the thorax in several different lines, as opposed to doing kind of the more discrete points recommended by Liechtenstein or Volpicelli in the International Consensus Statement, or Tierney in his 9-zone scan. Um, and so there's an advantage there. You get to see more surface area of the lung, which is super interesting. The disadvantage is that you don't see a full respiratory cycle at each of those points. And for those of you who've done lung ultrasound, you know that sometimes you place the probe down and it's like, oh, A-line pattern, then over the course of the respiratory cycle, the B-lines appear and disappear. So I wonder if sweeping's gonna allow us to miss those, or is it going to, through integrating it into a single picture, allow us to very quickly see the entire lung? The real challenge at the moment is, and Volpicelli proposed and demonstrated using this during COVID. The real challenge is that most of the evidence we have for how to do lung ultrasound, and more importantly, how to interpret lung ultrasound, that scoring system by Beaumont and others, was done with discrete points. And so I don't know what to make of a sweep image without the context of all the studies that have been done before. So it's not that this shouldn't be done, but gosh, we need a little bit of sweep and point driven to understand what information is different between those two techniques, so we can talk about how interpretation should be different between those two techniques. But I have this dream state. I mean, gosh, think how cool it would be where, like, the respiratory therapist comes by in the morning, checks the plateau pressures, and does a quick sweep of the lungs and the 4 zones they have. They do it in 60 seconds or less, and that's saved to the machine. And you can pull up the visual cue of what their lungs look like in the same way that you'd be pulling up a daily chest X-ray in the era when we did daily chest X-rays, but without the radiation and without the unnecessary equipment expense, because this is a machine that's there, it's by the bedside, and doesn't cause any harm to the patient to do it.
Well, I don't see any other questions coming in, and it looks like we're getting toward the end on time. So big thank you to Dr. Cameron Baston for taking the time today to put together this excellent presentation and for hanging around to answer questions for us. Thanks so much for being here and sharing your expertise with everybody.
Thanks so much for having me, Chris. This has been really fun.
Awesome. A quick reminder that you can watch previous webinars and sign up for upcoming webinars on sonosite.com/behind-the-scan webinar. And you can go ahead and scan that QR code right there. That should take you right to the page where you can see previous and coming up webinars. Thanks so much for everybody for joining us today, and we'll see you at the next webinar.